Just so you are all aware, we'll show you 2 features that will tonight make our conversation a little bit different than we've had in the past. So in the past, we haven't had this really awesome platform. We're using a webinar platform now on Zoom. So you'll notice that you can see at the bottom of the screen a Q&A section and a chat function. Both of those will be super helpful for you throughout the event to be able to chat with us and with each other. So the chat feature is really for you to have a conversation however you see fit among all of the attendees of the event. The Q&A function is really where you should post your questions that you want to have each of the panelists address. So I think we will get started and share everything quickly since we only have an hour for this. Tonight we have 5 lovely panelists. We have Dr. Sarah Rowan, who will begin our presentation from Denver Health, Angie Nelson, who is from the Denver Department of Housing Stability, Renee Palacios from Denver Rescue Mission, Jacob Wesley, and Deanne Witzke from the Colorado Coalition for the Homeless. Each of them will spend about 10 minutes presenting, and then we will go right ahead and open it up for Q&As, which I'll moderate and pull as many of the questions as we can possibly get to in that time frame. So without further ado, I'm going to stop sharing my screen so that Sarah is able to go ahead and share hers. And I'm going to turn myself off.
Thank you, Meredith. Please let me know, give me a signal of some sort if things aren't working as they should, but I'm going to assume they are. So thank you for the opportunity to speak today, and welcome to everyone. My name is Sarah Rowan, and I'm an infectious disease doctor at Denver Public Health. I've been involved with the testing aspects of COVID-19 since the beginning of the epidemic, because in my normal life, my team does outreach testing for HIV and sexually transmitted infections. So it was a natural fit. So I think I have 10 minutes and quite a few slides. Well, not too many, don't worry. But I just wanted to set the background on testing among people experiencing homelessness. You know, in the beginning, we were hearing reports that rates of COVID-19 among people experiencing homelessness in certain shelters in Boston and San Francisco were as high as 66%. So it was really terrifying. And there was clearly a need to start testing right away. We were part of a joint task force in Denver that was pulled together out of necessity. And the task force involves members from the Colorado Coalition for the Homeless, Denver Public Health, Denver Department of Public Health and Environment, and many of the large shelters in the region. So the task force together looked to CDC guidance and developed some principles from which we would develop our testing programs so that we could identify folks with COVID, symptomatic and asymptomatic, and provide support for people who are sick and provide isolation options for people to prevent transmission. So we, Denver Public Health, started testing in May of 2020 in shelters, and we did our first encampment testing in June of 2020. And just to kind of show you the pictures, you know, this is the National Western, which was a temporary shelter early on in the epidemic. And then the Coliseum here, that's the arena that is like the home of roller derby and fossil shows in non-pandemic times. So this is the kind of temporary shelters where people are staying, and you can see that beds are very close together. People are sleeping close together. So clearly there's a lot of risk. And then as anyone who has worked with communities experiencing homelessness knows, there's a lot of medical complications. And so therefore the risk of hospitalization is significantly higher than the general public. And this box up at the top shows that the percent of cases of COVID-19 among people who are experiencing homelessness is about 2% of all cases. And yet, compared to those who aren't experiencing homelessness, people who are much more likely to be hospitalized. So 28% of the folks who have developed COVID, have acquired COVID, have been hospitalized compared to 9% in the general population. So this is clearly a high risk situation based on living conditions and sleeping conditions. And the consequences of acquiring COVID are actually potentially much worse. So this is pretty serious, a pretty serious issue. So we jumped into the testing arena in May with a partnership with DDPHE, and they have some, the federal funding to support testing, which they subcontracted with them for public health. We test through the state lab. So the lab provides the testing, the state lab provides the testing kits and the lab support and the results. DDPHE pays for staff time for testing. So we have time cards that way and some equipment. And then Denver Health also donates in kind support for testing. DDPHE and DPH and Denver Public Health have been doing testing. Here's some pictures of my team. This is outside of the National Western Complex, which was a temporary shelter that's no longer being used for a shelter. And then you can see some outside the Coliseum. And then this is in the park in front of the Capitol, this lower picture. The testing we offer is voluntary, but it's incentivized with gift cards because we really want to test regularly to know how many people have COVID, what's going on with the epidemic, and also so that we can provide support for people who test positive. And my colleagues on the call will be talking more about the options for people who test positive or people who have really high-risk conditions for complications of COVID. So our testing program, and I'm happy to answer any more questions in the Q&A, but at the beginning we get consent to test. So we tell you who is going to get your information and make sure that people understand that this is a nasopharyngeal swab and here's what we do with it. We ask socio-demographic characteristics, race, ethnicity, gender. We also collect information about symptoms so we understand the fraction of folks who are symptomatic among those who we test. We do PCR testing, so we tell you if you have the virus, so antibody testing, telling you if you've had it in the past, PCR, if there is virus or virus fragments present currently. We've done antibody testing in people experiencing homelessness, and that's performed on blood swabs, on blood samples. The PCR is done, as I mentioned, on nasopharyngeal swabs, which are pretty uncomfortable. And then just a comment that those with prior PCR tests were not eligible to be retested, but they were eligible for antibody testing, of course, because we want to get a sense of who's had a prevalence of past infection in the community. We now say that if you've had a positive test in the last 90 days, you can't retest. But in the beginning, it was just if you've ever had a positive test, because we know that the positive test results hang on for a long time and they don't necessarily indicate current risk of transmission. So our results, so we've been testing, as I said, since May, and as of Monday of this week, so we've done, I think, 2 more testing events this week, so this is a little bit behind, but as of Monday of this week, we had tested 3,678 people, and of those 4% had tested positive. You can see the racial breakdown there. Most people don't have symptoms because the shelters have excellent systems in place to identify people with symptoms. So mostly we're doing asymptomatic testing. We've done most of our testing in shelters, but we've tested a handful of folks in encampments, and the vast majority are men. And interestingly, the age distribution is pretty wide. So there are individuals in the 19 to 34-year-old age group, all the way up to the 55 to 64-year-old age group. That's this kind of bottom box here. So it's really an older population, than I would have guessed a year ago. And we also ask about high-risk conditions. Do you have diabetes? Do you have high blood pressure? Anything that will put you at risk for severe COVID? Because if so, it's possible that patients can get, or individuals could get a motel room so they could isolate and decrease their risk of getting COVID, because if they did, they could get severe COVID. Here's just the last 2 months worth of testing results, because I can put the whole table on here and you wouldn't want to see the whole table on a slide anyway, but you can see about how many people we test per event. Here's the crossing on the 6th, the Samaritan House, the St. Francis Center, which is, a day shelter, and the percent positivity over here, we had this crazy outlier at 48th Street on the 29th of December, which led to interventions and significant follow-up testing. And now, fortunately, that outbreak seems to have passed. But that's really a pretty stark warning at what can happen if we're not vigilant. And then this kind of gives you the rates. So the blue bars are number of tests and the green line is percent positivity. And you can see that we've had percent positivity among our testing events, generally less than 10%, but then we had that one really high percentage. Encampments were an area of interest in the summer by many stakeholders. And so we did work closely with CCH to test it in encampments. We tested, this is a calendar that shows when we tested at shelters and when we tested in encampments over the summer. I have this sort of summary here in this visual. And I will try to be quick, but just to show you that we were at 4 unique shelters and we were at 3 unique encampments. And we did antibody and PCR testing. So we did draw blood in the middle of parks, which is not the easiest thing to do. And we found that the folks in encampments were generally younger, less often men. There were more women we tested in encampments. There were some racial and ethnic differences. And the people in encampments, sorry for the lineup, were more likely to be symptomatic because they didn't have a screening process in place. And then what we found was that the folks staying in shelters had a significantly higher likelihood of being positive than those staying in encampments. And also men were more likely to test positive than women among everybody we tested over the summer. And then we looked at antibodies to get a sense of past infection. And 24% of the folks we tested in encampments in shelters were positive versus 8% of the folks we tested in encampments. And we did control for gender because we wondered, well, maybe men are more likely to stay in shelters and that's why we're seeing this difference, but the changes were still significant when we controlled for gender. So just a couple more items that might be of interest. We're now using a rapid test in shelters. It's called the Binax now. It's a rapid antigen test. So it's not testing for the nucleic acid, it's testing for an antigen on the outside of the virus. And we've tested 777 individuals as of actually a week ago. 49 were symptomatic, the majority asymptomatic. The disease prevalence was 7% among this population that we tested. So it's a little higher than a lot of other cases, but it's because that 35% prevalence testing event was included. And we've seen 25 true positives and 32 false negatives. And what that means is that in 32% of the cases, or 32 instances, the PCR was positive, but the swab missed it. And so that gives us a sensitivity of 44%. So that means that in all people who have COVID, this Binax rapid test picks up the COVID in 44% of the cases. So it's almost like worse than flipping a coin. However, if we do pick up COVID, you get a result in 15 minutes and you can support people with the resources that they need immediately. So we find it useful and we're not really seeing false positives. So if it shows that somebody has COVID, great, we can take action. If it shows that they don't have COVID, we still need to get the PCR because we don't really believe the negative result. Just some issues in my kind of last minute here is partnerships. This has been really a major effort at developing partnerships across the city, and none of this would be possible if we didn't work together. DDPHE, CDPHE, Colorado Coalition, all working in really, really close coordination for this. Results disclosure and referrals is really run by CCH. So we're providing the testing and then we work closely with the Colorado Coalition to deliver results for the PCR testing and support people for transfer to other places. We work with DDPHE to prioritize and schedule and coordinate. And the antibody testing has been somewhat helpful for public health planning. Incentives are interesting. There's a question about how affordable it is to continue to offer incentives. Are they coercive? We know they work, and we feel like it's important to do surveillance testing to keep shelters, so we know how much COVID is in shelters. But they can create perverse incentives as well. And so folks who've tested positive for COVID in the last month really shouldn't retest. And yet if there's an incentive there, it's hard to, it's hard to not want to do that. And we work together on data collection. Sharing protected health information is kind of a sensitive issue during an epidemic. There's a tension between public health need and personal privacy. And then trust is just an issue that we won't solve now, but it's something that affects all of our work. People also, I would say, have pandemic fatigue, and they're, even with a gift card, they're a little tired of testing. So the way out of this is the vaccine, and people experiencing homelessness don't have any specific prioritization in this schedule. And so they may not get vaccinated until their number is up for other reasons like age, comorbidities, or phase 3 general population. But we are trying to coordinate so that if people experiencing homelessness do get prioritization for some reason, we're ready so that we can efficiently provide vaccine in shelters and encampments and other locations that serve people experiencing homelessness. So this is my thank you slide, and I will stop sharing my screen from here. Thanks.
Thank you, Sarah. So I kind of jumped around in the very beginning of this, and I appreciate all that you were sharing with us, Sarah, around how this all works, because it's very complicated and that there's a lot of people that need to be served in spaces that it's very difficult to serve them in. So next, I want to bring in Angie Nelson, who is going to be able to talk about kind of how the city structured this and the importance of having a response from the city as collective instead of individual, where we've seen around the country that it's in some cases has been more individualized, which doesn't allow us to do the great work that we've been able to do the last almost year now. So Angela, without further ado, you're up.
Super, thank you. And thanks again for the invitation to come and join today and be able to speak to everyone about the work that the city and our partners have been doing to try and help keep people safe, housed, and connected throughout this pandemic response. So my name's Angie Nelson. I work with the Department of Housing Stability for the City of Denver. The Department of Housing Stability is in place to help build a healthy and housed and connected Denver, doing this by investing resources and creating policies to help resolve episodes of homelessness for folks, as well as creating opportunities for people to connect to affordable housing and to housing opportunities at any income level. So that's a little bit about who we are. COVID has certainly spotlighted for us and intensified the need for the services around supporting folks who are experiencing a housing crisis or at risk of involuntary displacement, to ensure that our very most vulnerable neighbors and community members can stay safe and healthy. We have relied on our collaborative relationships with nonprofit partners, other City of Denver departments and agencies, as well as regional, state, and federal partners to help create a robust response. That interdependence, partnership, and collaboration has only been deepened as part of our pandemic response. And want to take a moment just to call out some of the partners that have been so integral and so key to the work that we're doing, and several of them on the panel with me tonight. Catholic Charities, Coalition for the Homeless, Colorado Village Collaborative, the Dolores Project, the Gathering Place, St. Francis Center, Salvation Army, Urban Peak, Volunteers of America. We had Colorado National Guard, Human Services staff being deployed, and then of course our partners in Denver Public Health and Environment, and with Dr. Rowan and the team at Denver Public Health, as well as many other community service partners. So just to give you a glimpse that this is such a widespread kind of response, and we've all taken seriously the charge to help keep people protected. So again, just the pandemic response has really brought together new collaborations, deeper collaborations among city partners. We literally could not sustain a program by program response and had to adjust to behave more like a system, sharing resources. If you remember early days, there was such a shortage of of everything. It wasn't just us going to Target and not being able to find toilet paper. We couldn't find toilet paper from our big industrial suppliers. And so, we really had to come together and learn about how we shared resources and worked to get services to folks immediately. I would say that our pandemic response has also served to accelerate some of the service models that we had hoped to implement. So things like 24/7 residential shelter, things like safe outdoor spaces, things like our outreach team to large encampments, while also helping us to pilot brand new service delivery models. So activated respite and protective action, the things that you're going to hear more about tonight, are brand new ideas that had not been in place in our community before. So early days with COVID, prior to COVID, we had a shelter network with a capacity of around 2,100 guests per night. That was the capacity. And we saw, we would serve roughly 1,300 or so guests per night within that capacity. And as the reality of COVID was impacting and hitting our community, and we recognized the need to create more space for physical distancing within our shelter environments, we saw a reduction in our shelter capacity, significant reduction down to about 935 guests within the resources and the shelters that we had at that time. Some of the other factors that impacted our shelter network were things like the ability to maintain volunteer staff. So many of our shelters and nonprofit partners rely on volunteers to help support their work. And we had limited personnel who were able to stand on that front line and help provide shelter and essential services to folks. I think the availability of materials and personnel, as well as infrastructure to allow people who were testing positive for the virus or who were at high risk for complication if they were to contract the virus, there was no infrastructure in place to help support those folks at that time. And so we knew that we needed to spring into action and figure out some solutions. And real quick, before I move on, I did want to say we've since worked to bring that capacity back up, and our capacity now is around 2,500 guests per night that we're able to serve in our shelter network. So while we saw that immediate impact from COVID bringing our capacity down, we've worked extremely hard to bring that capacity back up to meet the need in the community. So some of the things that we've done, these strategies that we've implemented. So the first of which just being our sheltering mission. So taking lead to direct federal resources such as FEMA or federal coronavirus relief, our federal emergency solutions grant, as well as state and local resources to prepare for, respond to, and prevent COVID infections among people experiencing homelessness. So for us, that looked like standing up auxiliary shelters. So those pictures that Dr. Rowan shared at the National Western and the Coliseum. We stood up a couple of rec centers as temporary shelters. We've worked to enhance sheltering at existing congregate shelter sites. So whether that's through, the Denver Rescue Mission or the Salvation Army to help get them additional staffing or materials to help provide a deeper sheltering experience so that folks could stay indoors 24/7, so that folks could have a place for their belongings and a place to interact in free time, just creating a deeper level of service for folks. We opened up 2 new non-congregate shelter facilities, so utilizing motels in order to provide shelter for women and trans individuals. And we increased access to non-congregate shelter for families. So we already have a history of serving families in our community, both in congregate shelter facilities such as the Samaritan House or Family Promise, but we also expanded funding and support to allow families to be served longer and more deeply in a motel environment. And as I spoke to before, we accelerated our plans to really implement 24/7 residential shelter. So the next area that we worked on to enhance our COVID response was around activated respite and protective action. And I know my partners from CCH will be speaking more deeply about that, so I won't go too far, but just to say that Denver has acquired over 800 hotel rooms that are available to unhoused individuals considered vulnerable to COVID-19, including those over the age of 65 and those with underlying health conditions. The other day, someone shared the story about a guest in protective action getting their vaccine, and it really made me tear up and was an emotional experience thinking about how we were able to work together to keep folks safe long enough until that vaccine could come through. And we still have a long road to go, but that one person is a good example and picture of the good work that was done to keep people protected and safe. Another one of our core efforts was around supports for unsheltered persons. So you mentioned the pilot for street outreach to large encampments. So combining a health and public health response into encampment settings, the pilot for safe outdoor spaces, to allow for additional support services for folks outside, coordination with the Denver Department of Public Health and Environment for increased access to hand washing and restrooms, testing, as well as vaccination coordination, and the STAR pilot program with Public Health and Environment and Denver Police that's brought a more person-centered response to community needs, utilizing medical, mental health, and peer support in more of a co-responder kind of effort. And then we've also been really centering our work around rehousing. So knowing that as always, front and center, the solution to an episode of homelessness is housing. And while we can work to improve our shelter system, we want to work to get as many people as possible into a more stable and permanent housing environment. So we increased funding to help those who can to quickly exit from their experience of homelessness through short-term rental assistance and supportive services, and are really capitalizing on this unique opportunity of so many folks steady in one place through these motels to try and help engage with them towards housing navigation to a more stable housing exit. I know I'm almost out of time, so I'll go quickly here around, I think this slide speaks to the work towards rehousing, and while we're still in the thick of an pandemic response, and to Dr. Rowan's point, staying very vigilant about how we ensure that we don't have a wave of infection sneak up on us, we're also looking to the future and trying to make sure that we can fill gaps and meet needs to help folks secure long-term housing. And then want to also just share with you all the work of the Department of Housing Stability is not only around homelessness resolution. Our Housing Stability Division has been integrally involved in trying to help prevent an inflow into homelessness for people who have had really significant and negative impacts from COVID-19 on their work, on their income. We've seen over a 700% increase in demand for our temporary rental and utility assistance programs, and have been able to serve folks, almost 1,000 unduplicated households in 2019, increased to over 2,500 households through the pandemic response so far. So we are really utilizing our resources to help prevent an episode of homelessness. So what's next for us in this response? Continuing to administer those emergency resources to keep people healthy, housed, and connected. Continuing to test across facilities serving people experiencing homelessness, coordinating for vaccination to help make sure that that's available for our folks in our community, working with partners on a rehousing strategy that leverages all investments, supporting 24/7 sheltering at existing facilities moving forward, and expanding our options beyond the emergency to continue to address gaps in our capacity. So thank you so much for hanging with me. And with that, I'll turn it back over to Meredith.
Thank you, Angela. That was perfect. I appreciate you very much. So I'm sorry to report that Renee had some computer difficulties that will not be able to be fixed tonight. Sounds like they need some IT assistance and they have gone home for the evening. So we're going to move on with our next panelists, who are Deanne and Jacob, and they are both from the Colorado Coalition for the Homeless. So they will be chatting with you next.
Hi, everybody. So what you're not hearing is the 80 hours a week each that those two previous staff members and so many other staff put in to make all that work happen. So I kind of wanted to start by just telling a little bit of that story of what it was like to be one of those people and kind of what our introduction was to this whole project. So at the start of COVID, when it really started to spread and get affect the homeless population, we started having clients come into our health center to get tested. And all of a sudden we had these folks who were tested, they were suspected to have COVID, and we didn't have any place to send them. We didn't have any place for them to safely isolate. So our doctors were scrambling and we're like, we got to get these people into a motel. What are we going to do? How do we safely do that? And so I said, okay, I'll drive them, you know, so we get all the clients a mask, right? And this is before masks are ubiquitous. I put on a mask and, you know, we're driving around trying to figure out which motel will take us. How do we do this safely? And one of the clients is just so sick, coughing constantly. The mask keeps falling down. We're in this enclosed van. It's like 35 degrees outside, right? This is still kind of the end of last winter. And, you know, I'm just kind of freaking out. We finally find a motel for them to go into, which ironically ended up becoming our first activated respite motel. Became 100 of those 700, you know, plus units that eventually turned into protective action. And then so I get the clients there, I get them some food so that they don't have to leave the motel and potentially expose people. I go back to the health center to report what happened and to say how it went. And at this point, it's like 7 o'clock at night, but a couple of the doctors stuck around to kind of see how it went. And, you know, I'm kind of telling them and they say, well, you know, that's great. You did great work. Just so you know, you have your mask on upside down and inside out. And so at this point I'm freaking out, right? I'm like, I have to have COVID for sure. I was just in this van. I'd never worn a surgical mask before. I had no idea what I was doing. And I just went home just with a whole lot of emotions, not knowing that this was really just the beginning of a Herculean effort to do all the stuff that Angie and Sarah just shared. So I just wanted to kind of share that bit of a personal story of how we started all this work.
Thanks. And so similarly to Jacob, I also work at the coalition. I'm not a healthcare professional by any means. I work in housing. And so that is how I got called to the table to help find hotels and spaces that we could help folks isolate, because I believe the title of this session is when you are told to stay at home and isolate, but you have no place to go, what do you do? And so let me share my screen. Give me one moment to get my life situated here. So that's kind of a federal mandate. It's actually happening internationally. We're being told to stay at home, yet the population that we serve has no place to go. And as Sarah Rowan shared in her slides, the prevalency rate at shelters was relatively high. So we knew that our population, who's already extremely vulnerable medically, was going to be at even more risk because they are staying in confined spaces. And Jacob and I can go into that a little more later. And so CCH, we have our mission is focused around housing, healthcare, and advocacy. And so we do a lot of integrated work at CCH, but this was for me, the first time that it truly was forced to not just integrate, but to kind of like step on each other and really meld together in order to respond to this, because we needed housing, we needed healthcare. And so I've shared on the screen here, hopefully you all can see, our mission was to provide a COVID response with excellence. And our objectives were to flatten the curve, to minimize poor outcomes, and for our agency to make sure our staff are safe. And we started an incident command system, so kind of took what the regular functions were at CCH and kind of broke off a group to respond to the virus specifically. And many CCH folks on the call were involved in that response. It involved 7:30 meetings for everyone every day, 9 a.m. check-in, 4 p.m. check-in, and then I believe the executive team met every evening as well. And this was Monday through Sunday, no longer a 5-day work week. And so our first thing that we worked on was thinking, you know, our healthcare system, if somebody tests positive who identifies as homeless, they would be, what is the healthcare system supposed to do? The person may not need emergency care or an ICU bed. However, if they're to go back to shelter, they would be spreading in the hundreds. And so kind of this chart here shows our idea that if we could provide some kind of respite facility for people to isolate who are positive or awaiting a result, we would de-densify the shelter system and allow the ICU beds to be used for people who truly need it. And again, as Sarah and Angie shared, we created our Denver Joint Task Force. That's where a lot of these decisions were made. And as Jacob said, our first activated respite started at a place called the Western Motor Inn. In the beginning, it was really ragtag, just figuring out what to do. It's 100 rooms and we filled relatively quickly. The National Guard was deployed. I don't know I can't see your beautiful faces in the audience, but I'd never worked with folks in the National Guard before, and suddenly they were there looking to us for direction of what to do. The Denver Human Services team sent over staff to provide 24-hour care at the facilities. I created an intake system so that we could keep track of our census and the inflow and outflow. And Jacob's team created case managers who are providing assistance to the medical team and kind of working in tandem to make sure basic needs were met. And we've changed a lot over the years. So let me show you a little bit more data. This is how our intakes per week looked originally. So there it is, that first week, we had 8 people at the hotel, and it moved steadily. You can see that we peaked in April and May, and that's fairly consistent with what was going on nationwide. We had a decrease in the summer. We've seen an increase this winter, with the highest point being 78, and now we're regulating a little bit more, hopefully because of vaccines, but because of a lot of different collaborative efforts to flatten that curve. And some ways that we've kind of pivoted, we started with one activated respite site and then ended up having 3 total. Jacob is going to talk about protective action, but as time went on and we were seeing less positive cases, we transitioned 2 of the activated respite sites to protective action. And at this point in time, we have 1 activated respite site at the La Quinta. You'll see there's 107 total rooms. However, then around this time of year when the virus spiked again, we actually, rather than getting a whole nother hotel, moved to double occupancy at that hotel. So our clientele are sharing a room. And so we now have capacity, our bed total of 188. And so there's one more dashboard, sorry. This dashboard kind of shows the way in which we make our decisions. And this is shared every day with the city, which Angie represents, and Sarah, Rowan, and our other medical partners. So this shows our total capacity line is here, I guess, is orange. And we never want to be hitting orange. So we're measuring, okay, if we're at this many intakes per day, how fast would we be getting close to orange? So right now, looks like we're at about 40 rooms occupied. So we're not quite close to this, but this is how we've kind of been monitoring throughout the activated respite system. And Jacob, do you want to talk about PA?
So, right, we started with activated respite just kind of literally from the end of my last story, where our first priority was how do we keep people who we suspect have COVID out of congregate shelter settings, right? We had to have a safe place for them to go. And then quickly we transitioned to, okay, well, what about those who are 65 and older? What about those with chronic health conditions that really put them at severe risk to develop, potentially fatal illness if they contract COVID? And so then that's when we partnered with the city to create other motels that were called Protective Action. So to house those with those qualifying conditions. And that ended up growing into, I think Angie's slide said maybe 709 rooms, but it's about 700 rooms of protective action. And what Deanne and I did, again, I like to kind of share the human side of this beyond just the numbers, is we went to each motel when it started, right? So these motels weren't set up to be these types of sites. So we had to create staffing space. We had to get computers. We had to, think through all of these different logistics. How do we get our computer network out there so we can have our electronic health records? How do we loop in medical staff? How do we do all these different things? And so as that grew, it really became a goal of ours to not just help these people stay safe in these motels. Obviously, that was goal number one. But for us, all of a sudden, you have all these people who used to be staying in the shelter, who need permanent housing. You have them staying at a place where we have our staff working, and our staff are experts in getting people housed. So we thought, well, this is perfect. Let's pull in as many case managers, as many shelter support staff, as what we call them, as possible, to not only help maintain the milieu, but also to help get people housed. And I'm so thrilled to report that we've been able to house 101 individuals through this process. So, obviously that means at the end of this, people will still have to, go back to congregate shelter. Ideally, they'll have been offered a vaccine before doing so they can do so as safely as possible. But to house 101 people has been amazing. It's really, again, from the kind of human emotion aspect of it, it's been such rewarding work to do, because I can't tell you how many of these clients you go and you check in on them after a week in the motel and just say, hey, how are you doing? And they're like, here, come on in, I want you to see my house. Like, they see the motel room as their home. People are setting up pictures, they have all their things out, like this becomes their space. And so what we want to do as much as possible is provide them with that permanent space when they leave there, since we know these motels can't be that, unfortunately. So that's been a huge focus of ours. And, one of the other, really rewarding things, like Deanne said, is partnering with National Guard, partnering with, other agencies. Denver Human Services was our partner early on. It transitioned to Salvation Army. They're the ones who are there 24/7. So if someone has a crisis at 1 a.m., they're there to assist with that. So it's just been a truly collaborative process across the city and several homeless service providers, and it's just been an honor to be a part of it. And then what I do is, Meredith said in my introduction, is so I'm the director of outreach and engagement. So a lot of what the response we've been doing is on outreach as well. And so Sarah, I believe, already kind of shared this graphic. Shared is a nice word. I was thinking stole it from me when she first showed it. No, I'm kidding. It's really more hers than mine. But we partnered with Sarah Rowan's team to do this encampment testing. That was a big thing our outreach workers did, was go out and coordinate with her team. And we went out days in advance to kind of try to educate people on what was going to be happening. There was a lot of hesitancy to participate in this type of surveillance testing. So that's been really amazing. I think the city dedicating services to that, to saying, we're not only going to test those who are a captive audience at shelters, who there's the environment to do that testing, but we're also going to find a way to go outside and go to these large encampments and test them as well, to me was a really key response the city had. And another one is, as Angie mentioned, was this development of a new team called SOUL, which is Strategic Outreach to Large Encampments. So now we have a new team of 4 staff and a nurse who are dedicated just to large encampment work, who are dedicated just to going out and, you know, right now during COVID, make sure people are safe, make sure people are educated, make sure people have masks, make sure they know where hand washing stations are. If they develop symptoms, helping them get tested and get to activated respite. You know, that's really been a huge effort and something that, you know, we've been really proud to partner with the city on. And it was also really rewarding to see the low positive rate, and also selfishly kind of reassuring, because we have outreach workers in these large encampments constantly interacting with tons of people, right? Which kind of feels counterintuitive to what most of us have been doing, you know, isolating and, you know, avoiding people in our homes and socially distancing, to be in these large encampments. So to hear there was a low prevalence rate, again, to kind of speak to the human response of this, not just the data, was really reassuring to us, and also helped us know that we weren't bringing COVID into these camps, because that was one of our concerns, is could we be bringing potentially something in? So yeah, I can't say how honored I've been to partner with everybody on this call and to address this as a collective. I think that's why we've been so successful.
Yeah, and I'll finish by highlighting the safety piece, because again, Jacob was in a car with 3 COVID positive patients with a mask on backwards. And, you know, all of us in this room, this virtual room here, in March had different experiences with what it was like to adjust to a pandemic and to a virus that we didn't know anything about. And I'm not sure what you all can see on your screens, because I don't see you all, but if you can see Meredith Ritchie's background picture, it's her on a little step stool, and behind her, it looks like she's at Sam's Club or Costco. That's actually their office space at CCH. So Meredith and team created a warehouse internally for us to collect PPE, to collect, like Jacob said, computers and pens and items that we would need to start functioning at 8 different sites with 800 rooms across the city and county of Denver. So just want to highlight the fact that there was a lot of folks behind the scenes working logistically to make sure that this system worked, and we're really grateful for that. There's a whole team of folks that work on the turns of the room. So every time a COVID positive or negative patient exits, we partner with Bayad to come in and do the cleaning of those rooms. And again, thinking about what kind of PPE was required, what we did and didn't know about the virus, it's been literally a process that has changed every day and has taken a huge team to make function. So I'm looking forward to the Q&A. I'm not sure if there's anything else to say for now. Thank you.
Thank you, Deanne. And yes, that's my picture in the warehouse. We do have a few questions, and if the presenters wouldn't mind popping your screen or your video on, so when it's your turn, it's all of you are kind of hanging out together, and I'm going to put you on Gallery View so we can see your faces. Perfect. Okay, so one of the questions that, let me pull up right here. One of the questions that we had was about trauma-informed testing, and that was actually kind of interesting to me, because when we're talking about people experiencing homelessness, now we're asking them to have someone else in their very close quarters to them and sticking something up their nose, which is generally uncomfortable. So was there any ways you had to approach this as you were doing testing, or figuring out what that might look like as we moved forward?
That's a good question, and I don't have a real complete answer. I will say that many of the staff at Denver Public Health have had trauma-informed care training. It's I think it's something that's getting more traction among healthcare, and so fortunately we had, you know, pretty I mean, our leadership for testing was pretty informed and sets the tone. All the testing is consent-based. We ask, can I touch you? If you need to touch someone's head to do the test, give a lot of advanced description of what it's going to be like. You know, that this goes in about this far, it's uncomfortable, it lasts about 5 seconds. So I think we tried to do our best there. There's some people who couldn't handle that kind of testing, and we did not push it at all. I could get into the weeds about this a lot, but you know, oropharyngeal testing is not nearly as sensitive. If you just swab someone's throat, it's just not a good test. We did a comparison, basically a project, quality improvement project, to see if anterior nares, which is just swabbing the front of someone's nose, or saliva, you know, if that would do the trick, because that doesn't hurt. And I have had, you know, nasopharyngeal swab testing about 10 times, so I know exactly how it feels. And for people who don't have symptoms, it's not very sensitive. And so if the idea is to try to find COVID among people who are asymptomatic and could potentially transmit, we felt like we were kind of stuck with the nasopharyngeal swabs. But it's a concern that we're aware of, and I think it affects our ability to effectively test. And so then you kind of wonder, well, if some people just don't test at all, is it better to do a test that's not that sensitive? You know, and it probably is, and it's just a continual work in progress.
No, I appreciate that. That it is definitely a challenge. So I definitely appreciate that we are doing everything we can to make sure that people are respected and feel like they have the outcomes that they need, while still managing to get people tested so we can protect them. I have another question here of how many people are getting tested elsewhere might be experiencing homelessness. So if they're not tested at those encampments that you talked about, Sarah, are we seriously underestimating the number of people who may have COVID in camps? What are we kind of guessing around that?
Was the question specifically about people who don't go to shelters, who only stay in encampments, or just
who are not at shelters or tested at encampments? Correct.
Yeah, I think that's a population that isn't really being served very well. We do test at day shelters, and there's it's a pretty heterogeneous group of folks at like the St. Francis Day Shelter or the Gathering Place. So I think we have some work there. I know places like Harm Reduction Action Center, where some people experiencing homelessness go, they don't test on site, but they are pretty careful to refer people for testing if needed. But I think I would defer that question to others that are more familiar with the lay of the land.
Yeah, so definitely it happens where people are tested elsewhere, and those people are able to enter our activated respite as well. So we regularly get referrals from other hospitals who are seeing people who are COVID positive or they suspect are COVID positive, and they refer them to our activated respite to stay. So we've reached out to several area hospitals, we've built relationships, we build a referral process so that if people are tested elsewhere and report that they don't have a safe place to go, or they report that they're homeless, then they'll reach out to us and we'll help get them transitioned into activated respite to safely isolate.
And also just add real quick that, you know, there's many encampments and we only tested at, I think 4 or 5 different sites. So certainly we missed a lot of people that way. Although since we found that rates were lower, there is not so much pressure because people are kind of staying somewhat isolated at night. They're not sleeping in big groups and they're not inside. But a lot of people are not tested for sure.
Thank you. There is also a question here about people, and Angela or Sarah, you probably can answer this. People who are working with those who are COVID positive, are they being vaccinated? How are they prioritized in the list? And what does that kind of look at like? Because we know that people experiencing homelessness themselves are not prioritized throughout the state.
Angela, you could go ahead.
Okay, you may be able to speak more fully to all the segments of the state's prioritization, but at this point, City of Denver is following the state's guidance around prioritization categories for vaccination. So there's, group 1A, group 1B, there's a dotted line under which it includes frontline workers in settings where folks are experiencing homelessness, so folks in shelters. In group 1B, that includes social workers and other frontline staff characterized as healthcare workers. So some of our agencies that have healthcare workers, such as the Coalition, have been able to work towards vaccination for staff. Others have been able to get vaccinations figured out individually through their healthcare providers. So, filling out that link on the Kaiser website or going to the Safeway pharmacy page and registering as someone eligible in one of those prioritization groups. But currently, Denver Public Health and Denver Public Health and Environment are working together to try and set up some vaccination clinics for the frontline workers. And do just want to echo that there's a lot of advocacy happening right now from all of our public health agencies, from the city, all the way up to our partners at the state, to try and make sure that folks experiencing homelessness are given a special prioritization in all of this. So do just want to let folks know that that is front and center in our minds and something that we're working hard to try and achieve.
Thank you. So we only have 2 minutes left. So maybe if each of you could give us one snippet, very brief, of what you learned. What was this experience has been kind of eye-opening, I think, for all of us, but especially in this field, I think we've learned a lot of things. Can you just give me one short sentence or two of what you've learned in the last year?
I can go first because I've learned so much. I'm going to just go with the first thing that came to my mind. I learned that with people focused on a common mission, with multiple kind of stakeholder backgrounds, but an aligned mission, we can move mountains. I mean, we literally changed the scene of homelessness overnight in this community here. And so with resources that are designed to be flexible to support the work we need to do, we know what needs to be done and we'll pull together to do it. So we need more of that. That's what I would say.
And Deanne, the little booger, stole mine, but I would say that what I learned, and I don't mean to sound overly optimistic in the middle of a pandemic, but I do think sometimes it's darkest before the dawn. And I think what Deanne just said is actually going to carry well past the pandemic. So I don't expect that the increased partnership that we've had with Angie Nelson and Host, or Sarah Rowan and Denver Public Health, is just going to all of a sudden fade away at the end of this. I think this is actually going to transform in a lot of ways the homeless service response. So I'm really excited to be a part of that and to see what lasting bridges come from this.
I would take that and do the backwards view of that, in that I feel like, our team, CCH, some of the partners at DDPHE had a good foundation. And so having a strong team to draw on really gave us a lot of ability to do good work at a moment's notice. And so I really credit, my team and those that are partners with that. That we could come together was great, but the more we can create a public health infrastructure, the better off we'll be in confidently responding with competency and compassion.
Yeah, I think what I've learned a lot of is that the things that we already knew to be true, we were able to test in a really rapid and scaled up sort of way. So things like 24/7 sheltering matters. The ability to know where you're laying your head every night matters. That the dignity of your own space is life-changing for people. That our shelter and service providers are literal angels and superheroes that have put themselves at risk every single day since the middle of March to try and keep people safe. That additional resources makes a difference. The city has deployed over $54 million in the past 11 months to try and keep people experiencing homelessness safe. And we couldn't have done it without the influx of federal dollars flowing to help address this need. And so I think the things that we know to be true, that we need money, that we need housing, that we need individual spaces, that we need more partnership, has only been deepened and highlighted through this work. But ultimately, just the incredible partners who stand up every day and hold space for our most vulnerable neighbors.
Thank you. Thank you, everyone. I appreciate, and I want to end there. The only thing for our audience that I'd like to make sure to share with you is that we have 3 things we'd like you to do. One is that an email will be coming to you tomorrow that will tell you all of the things to do, so you don't have to remember, but if you want to write it down now, that's great. If you are not signed up for a coalition email, please do so. We are going to kick off the legislative session in just a few weeks in the middle of February. And there are lots of things that are going to impact people experiencing homelessness that will continue on well after the pandemic, and things that impact us right now. So renter protection, eviction crisis that we're in right now, all of that is still going to be very key, and there will be issues that we're going to bring to you and ask you to write your legislators about and call them and make sure that they are fighting the good fight with us. So please sign up for our emails. If you have signed up for our emails but you haven't put your zip code in, add it in. That way we can make sure that we're getting you to the appropriate legislator when you want to write them a letter. Otherwise, we're not going to be able to target you as well so that they can get the information that they need. And then so look for those action alerts. Ryan, or actually Jill, just put in the chat in the bottom that how you can sign up for our newsletter or our email list. Please do that. I'll also send that